Hello, this is Dr. Lynn Lucas-Fehm, President of the Pennsylvania Medical Society, and I am honored to have with me one of our former wonderful presidents, Dr. Wilson Jackson. Let me tell you a little bit about him. He received his undergraduate degree from Bowdoin College and graduated cum laude. He's got his MD from Northwestern University in Chicago. His residency following that, did his fellowship in gastroenterology and hepatology at Thomas Jefferson. He's board certified in internal medicine and gastroenterology. He's also a fellow of the American Gastroenterology Association, American College of Physicians, and American Society of Gastrointestinal Endoscopy. As I said, he's a prior president of the Pennsylvania Medical Society, and I had the pleasure of working with him as I noted his great commitment to improving patient care through physician advocacy. He's going to talk with us a little bit about his practice and his ideas on practice, as well as going into my presidential initiative that has to do with private equity. So welcome, Dr. Jackson.
Lynn, thank you. Thank you. I really appreciate the invitation. And first and foremost, I want to congratulate you on a wonderful year you've been having so far this year. As the organization's president, you've been a terrific torchbearer for the organization, really speaking on behalf of the physicians. Particularly around your initiative that we'll get into later, really resonates well with me. And I thank you for all the hard work that you're doing, because it's a fair amount of work and commitment for the part.
All right. So I think to start out, what we should probably let everyone know is, what is your current practice? What modality are you working in? Is it, private? Is it academic? So tell us a little bit about your practice.
Yeah, we have actually a very kind of traditional medical practice, or at least historically traditional. I'm in a private practice. We have a total of 5 physicians. We have 4 non-physician providers. And we are located in South Central Pennsylvania. And it's where I've been for my entire career. Been here for over 25 years. Excuse me. And we've grown organically. And we have 2 office sites on either side of the Susquehanna River, the East Shore and West Shore, and we have an endoscopy center. So from a practice perspective, we do not only an office, E&M routine office work, but also doing endoscopy procedures in a freestanding ASC. I'm a second generation sort of thing. I just kind of kept doing what my father had created, but did expand, build the practice out, brought in some partners along the way. We have a great group of total 4 partners I have to work with, plus 4 APPs as well. In terms of kind of how we got here, we've kind of carved out a practice in our area that's, because it's a second generation, we've been in the community for 60 years or so now. So kind of just a long-standing presence, and as a second generation of sorts. Myself, my partners all have deep roots in the community, and we enjoy that kind of traditional value that we hopefully bring to our patients, but also part of the community, being kind of members of our community. Our kids have gone to school in those local schools. They've engaged in all the sports and other activities in schools. We've become part of and become quite active in a whole wide variety of, activities outside of the medical practice itself. So we think we're part of the community in addition to providing medical care.
Did you ever consider changing the way that you practice medicine, private, in terms of perhaps employed, large health system?
Sure.
Where you're at.
Yeah. So I've been, if you look through the trajectory of the past 25 years of my practice, we've gone from really a dominant physician kind of private practice, privately owned practice model, to now a much bigger shift. And it's really been inverted in a very big way. We've maintained that traditional ownership model, but in those 25 years, certainly I've seen many practices become consolidated under health systems. I saw many practices kind of circle the wagons to this little bit. to try and join forces with similar practices. And we did that similarly in our practice. We were a small independent practice. We merged with another small independent practice, about almost 20 years ago now, to create a combined practice between the two. But we did that just to kind of pull some resources, but with the spirit of trying to maintain high quality care at an independent level. So I've seen the consolidation of practices being kind of bought up by private or by the health systems in the community. By the same token, I've also seen the shifts at the consolidation of the health systems. We in our area we have two dominant health systems. That's pretty typical now in the community or elsewhere in the state: Philadelphia, Erie, Williamsport, Scranton, Erie, Pittsburgh. There's really one, two, maybe no more than three large health systems that dominate the market, and they employ a large percent of the physicians. So a lot of our colleagues are now become employed within that larger health system. And they're perfectly happy. Many of them are perfectly happy in that model. We've chosen not to go in that direction at this point.
Do you think that there is a big difference in the care that the patients receive? Not necessarily good or bad, but different.
Yeah, you'd like to think that the care doesn't change. I can just tell anecdotally what patients share with me is they miss some of the continuity of the staff. There seems to be higher staff turnover in some of these employed models, and the patients notice that. So the person checking in at the window, the nurse rooming them, the nurse wrapping them. There seems to be some subtle social components to that patient care. Not that the care delivered is any less, but that personal touch in some ways I've seen change. Just again, what patients comment to me and some of my colleagues have shared with me. The value that becoming a part of a larger health system is, you have much deeper resources. You can bring more state-of-the-art care. You can afford those things being brought in. And so in many ways that the quality of care at that level is improved because you just have access to a broader, newer emerging therapies that a small practice may not be able to afford. We've been able to have the best of both worlds. We have good relationships with the health systems. We've been able to partner with them, you access to their hardware, so to speak, and their devices. So we've been able to leverage that relationship in a positive way for the patients and their care. But we've chosen not to become actually employed within the health system.
So it seems as if you have made this conscious decisions to remain independent and do partnerships with the larger health systems. I know at the same time, certainly you've been approached by private equity to join with them. Perhaps we can talk a little bit about that. And then I'd also after we finish that, just so you know what's coming up, is what do you foresee as the future of your model of practice, given the large health systems and private equity, which is what I'd like you to touch on for me now, if you would.
Sure. Any student of healthcare delivery in the United States has become well aware of the penetration of private equity into the healthcare environment. It's not new in healthcare, in other areas of healthcare, but in terms of clinical care, it is newer, and it's a trend I've seen over the past 5 to 10 years. And the private equity, has sees an opportunity to improve some of the efficiencies and kind of small private independent practices by themselves, each standing by themselves, can be challenging to manage, and they bring a level of expertise in terms of operation of the medical practices. They also bring some clout in terms of negotiating with payers, and they bring some economies of scale with that. Our practice has been approached, and we've had discussions over the years with some private equity companies, and it's certainly happened in my specialty, gastroenterology, in the state of Pennsylvania. I think the majority of previously independent gastroenterologists in the state are now part of a larger private equity entity. And that's true throughout our other medical specialties, dermatology, ENT, ophthalmology, dermatology to some extent, emergency room, emergency physicians, probably some pathology as well. So this is not unique to gastroenterology by any measure. And the model is quite effective. And those investors in the private equity see an opportunity to pull together kind of a very splintered medical field and bring it together to improve some degree of efficiencies. Personally, I like to think we run a relatively efficient operation as an independent practice, and that's it's not an area that I think we can hold our own against what the private equity has promised in terms of just operational efficiencies. They do bring capital. If a medical practice is struggling to make a purchase, a major capital purchase, partnering with the private equity is a great way to make those acquisitions and to broaden your portfolio of products and services that you bring to patients. So there's clearly value that they do bring. I think there's a potential for an ethical conflict for physicians, in terms of your duty bound to advocate exclusively for the patient on their behalf and what's in their best interest. Now those physicians become a shareholder in an entity within private equity. And oftentimes these things are kind of incorporated through a kind of a management service organization in order to keep the corporate practice of medicine laws at bay. And that's the vehicle, the mechanism by which they can kind of stay within the limits of the law, yet still have some equity in the larger entity. I think physicians need to be really careful about the potential ethical conflict they have between those two forces, so to speak, in terms of your stockholder in a larger entity and your advocacy for the patients. And I think that's where the private equity folks and your partnerships need to be really thoughtful on who you choose to partner with, because like any other industry, there's a range of motivations behind the scenes, so to speak. And I think if you go into that, if you pursue that partnership, you want to do your homework and find a partner that shares those values with you, because I think those values are at risk of being conflicted and being pulled in a way that I think it's not best for the patient.
Given the model of the way that private equity is set up, where usually it's a short-term investment seeking to make as large a profit as possible, and then package it up and resell it again. Some people have called that what they do is, yes, it may be efficient, but it's also an extraction of funding since it's about the profit. How sustainable do you think that model is with high quality patient care?
Yeah, so I use my own practice as an illustration. I think there's only so much revenue you can generate with the patient encounters, and there's an asymptote in terms of how many patients you can see necessarily, and how many quality care metrics you can meet at a given time. So there's a limit to how much profit you can pull from a practice. So in private equity, that second sale, you don't know who your owner is going to be at that point. What I've seen in some of these second exits, or the exit by the initial investing entity, is oftentimes they're sold to a kind of an annuity type fund where they're just looking for a revenue stream at that point. Oftentimes these private equities will say take 30% of the profits from the practice, and then that gets distributed to the investor buyer. And oftentimes these are just retirement funds for a pension plan, some entity, some business. So physicians potentially are ultimately working for a pension fund, for a retirement fund, for some entity, some business out there. That, which is fine. It's fine. The model that it works best for are people in my phase of my career, where you might have an ownership in a practice and you have an opportunity to kind of monetize that practice that you created over the years. And many physicians have opted to move in that direction. My concern, and what I've shared with my partners, is I don't necessarily think it's a great opportunity long term for the newer physicians, the young career physicians. But I'm not quite sure what that's going to look like when you have secondary and perhaps even tertiary buyers of your entity there, your practice. And like I said, at some point there's a limit to how much juice you can squeeze out of the lemon, and I think there's a limit to how those subsequent owners are going to extract their investment the practice. And I think physicians may be on the short end of that deal ultimately. So I think looking down the road, particularly if you're a young career physician, I really think twice about getting on board with these. It's they certainly have security, they certainly bring revenue, but I think you have to look at what that model will look like 10, 15, 20 years down the road if you're you're earlier in your career.
So sometimes the presence of private equity is not always transparent. Right? I mean, you were approached directly, so you knew who it was, but it's
Yeah.
not always that evident. Do you have any advice for younger physicians in particular to
Yeah.
how can they find out so they know what they're getting into?
Yeah. But the way we approach this is when we were having discussions with private equity, and I want to be really clear, many of my colleagues and who I consider my good friends, they have chosen that road, and my hat's off to them. They were very happy, and they have good partnerships, and they feel like they're really fulfilling their mission and their vision with regard to the patient care. Um, the model that what we approach this is, we listened and had a number of meetings over the years with a couple of private equity entities. But before moving forward, we actually hired an outside independent consultant who kind of brokers these deals. So they're sort of like a middleman in terms of the practice and the private equity investor. And no skin in the game. And we paid for him to come up and give us kind of a 3-4 hour discussion around this. And we felt that was a really valuable opportunity or way to kind of get ourselves educated. So we weren't necessarily trying to process all the information on our own. So we brought in a consultant who really helped us navigate some of this and just kind of look at the upside and the downside of the private equity approach there. So this, if I was counseling someone, I'd, one, seek independent counsel and advice, and two, do your homework, and two, their due diligence on who your future partner is going to be. What's their track record? What's their core values? What's their leadership style? Who's on their board of directors? What's their makeup? What's their experience? What's their commitment to healthcare? Because that's where I think healthcare distinguishes itself from all the other business entities that private equity has entered. Is healthcare is a little bit different. You've got patients' lives at kind of stake here, and I think you need to approach it with a little different philosophy than you would necessarily if you're investing in another business sector than healthcare. So I think healthcare requires a little more thought in terms of who your financial partner is going to be.
You're in an independent group, as am I, but in
Yeah.
theology, believe it or not.
Yeah.
So, what do you see down the line for independent practitioners like
Yeah.
us? Do you think our
And
models will survive?
yeah, it's a fair question, and I don't have data, but I can just comment on observation that I think the younger physicians are coming right out of their training programs, looking for their first job, or maybe they're they're making a quick move after their first job. Um, they don't necessarily want a traditional independent medical practice, and I think it's incumbent on organizations like the Pennsylvania Medical Society to educate these new graduates and the young career physicians about what opportunities there are out there. And an employed model works for many, academic models work for many, but I think they need to understand the full spectrum of the private equity employment model. But I think we need to have physicians educated about the independent model out there. And part of me would hope for a little bit of a pendulum swing in the other direction, as those early career physicians or younger physicians who became part of private equity decide that's not what I'm looking for, and they decide to come out and move into private practice. I'm hopeful there's going to be a little bit of a pendulum swing in that direction. There hasn't been yet, and there may well not be. And ultimately, you and I in our practice may be on the wrong side of history, and ultimately, the entire sector of healthcare delivery becomes employed at one level or another within private equity. I hope not. I think there's still a place for independent practices that if you do good work and you kind of lead with the patient care first and foremost, and the finances and the economics often follow.
Yes. We've had several younger physicians join my group, I'm happy to say, who said
Great.
they did not want to do that. So I'm hoping they'll be pleased as the
Yeah,
years go
yeah,
on. But
yeah,
they didn't want to be part of a larger health system and did not want to be, as they said, bought by private
yeah,
equity. So
yeah.
think
Good
there's
to
hope
hear.
for the future.
Good to hear.
Um, is there anything else you think our physicians should know, should do their homework about, should
Yeah,
uh,
yeah. I'm just gonna make a comment on just this is again my personal perspective, by no means representative of medical society and other organization, um, on the effect of private equity and all the consolidation in healthcare has had on the cost of healthcare, the cost of care. Um, when a private equity comes in and coddles together, a dozen practices, and then they go to negotiate with the payers, the commercial payers, they have a lot of leverage. And oftentimes when they will merge and bring on and acquire practices, they'll look at what their reimbursement is by any given payer. And since they're all submitting their claims under one tax ID number, they'll often identify that commercial practice that pays the highest. And then that becomes the new set point, which is the way these things work. And that's just business, so to speak. But what happened at the macro level, from my perspective, is all of a sudden the same care is being delivered, but at a much higher cost in any given community. So if you're a private business owner, let's say you own a garage, or say you own a series of small, restaurants in the area, or maybe kind of other businesses where you provide healthcare insurance for your employees, suddenly your premiums are being increased because that healthcare, that increased cost by the payers, is being passed on right on to the buyer of the health insurance products. So from my perspective, I think we need to think through what private equity is doing at a macro level in terms of the cost of care. Same care is being delivered, same level of quality being delivered, but it's suddenly costing more because of that consolidation uh, amongst the providers there. So private practices, just don't have that degree of leverage. But I think at the macro level, I think we need to be sensitive to the cost of care to the whole system. I think physicians, it's incumbent on us. We are the central part of the healthcare delivery model and the system out there, and we need to be cognizant of the costs that are incurred when we go down these roads of consolidation. Just a personal opinion there, Lynn.
yeah, I appreciate that. So
Yeah,
in discussing these, potential and a larger outlook, do you think there's a
yeah,
difference between private equity approaching a practice versus what we're seeing now when private equity takes over hospitals and some of the
yeah,
failures with that? There seems to be more, at least in the public eye, what you see in the paper. It,
yeah.
Private equity and hospitals don't seem to go together very well.
Yeah, and that's where I think when you look at who's holding the reins in private equity, who's holding the reins in the consolidation, it's not the physicians. It's not the physicians,
Not.
and I really kind of encourage our, particularly younger physicians to get themselves into a leadership track where you can become part of that conversation, because the physicians are not making these decisions regarding a real estate investment in a city that may have more value as selling that hospital and turn it into townhomes or apartment complex or condos or some other value of that real estate. Physicians, I think, have hopefully a greater awareness of the value that those health systems bring to a certain community in terms of care delivery and access to care. And I think physicians need to be part of those conversations. And I think we've been sort of boxed out to some extent from those board levels positions in the investment
Yeah.
areas out there.
And certainly you're talking about at a macro level, uh, having private equity buy a practice is one thing, buying a whole hospital and then having it fail and then selling
Yeah,
off the real estate can wipe out an entire community.
yeah, yeah,
So,
absolutely. And we've seen that in our own state.
thing.
And it's been tragic in my mind.
Yes.
These are some storied institutions sometimes that have been part of the community for, you know,
A long time.
it's
Yes.
generations and generations.
All right. Um, Anything else you think we should have covered? I'd like to open this up, to you.
Yeah, no, I just want to just express my appreciation for what you're doing here in terms of just trying to get this message out there. Because, the medical providers, the docs out there, they know what's going on. They know this is the lay of the land. But I think to the extent we can educate the public is even better. And part of that is you communicating with physicians, delivering that message, and those physicians communicating that to their colleagues, but also their patients, and the many physicians are community leaders wherever they're living, and getting that message out there. I think it's terrific. So I want to thank you for what you're doing.
Oh, just
You're
trying to
beating the
fill,
drum, man.
your big shoes. You were there before I was getting out there and advocating. So thank you is what I say back to you.